Hey, welcome everyone. Thank you for joining us again on this Friday afternoon. It's sunny out there, which is always nice. We're really excited to welcome you to our second webinar in our new Navigating Dementia series. My name is Diane Martin, and I'm an associate professor in the graduate school at the University of Maryland, Baltimore, where I also serve as director of our geriatrics and gerontology education and research program. So I want to welcome you. We're really thrilled to bring this educational program to you, which consists of a series of 5 webinars and 2 in-person conferences about Alzheimer's disease and related dementias, which was developed for a very diverse audience of care team members, loved ones, paid caregivers, employees of Maryland Agencies on Agency and the Maryland Access Point, and a range of aging service providers. So we thank you for taking time out to join us for whether it's one webinar or all of our events. We really appreciate your attendance. This spring 2024 series is funded by a generous grant from the Maryland Department of Aging, whose vision it is to change the trajectory of aging. The series has been designed and made possible by the efforts of the talented members of the Geriatrics and Gerontology Education and Research Program grant team, the G-GEAR program, Geriatrics and Gerontology Education and Research Program. G-GEAR is a University of Maryland-based program that facilitates interprofessional education and interdisciplinary research activities in the field of aging in partnership with campus affiliates and agencies and organizations serving Maryland's older adults and their caregivers. The series was created with the following objectives in mind: advancing your personal understanding of dementia, formulating realistic expectations based on the effects of dementia on persons living with ADRD and their caregivers, demonstrate confidence in interactions, which reflects evidence-based, unbiased, culturally sensitive approaches to care, create meaningful living opportunities for individuals living with Alzheimer's disease and related dementia in Maryland. A few housekeeping items for you. At this time, please be sure to have completed your pre-survey questions using your unique participant ID code, which was provided to you in the Zoom invitation. I will be going into my email as soon as I turn it over to Dr. Majid. And for those of you who are emailing the G-GEAR account or me personally, I will go through and I'll provide your unique ID number so that you do have that to complete the survey. So we apologize that some of you did not get that. The Q&A box is the place where you can drop in anytime to type in a question during the webinar or a place to comment. The presenter will address your question before the webinar concludes. If you're here today and would like continuing education credits, you must be present for the entire session. Due to the large number of participants, we request that those seeking CEUs stay connected afterwards until you're confirmed. The system is going to auto-confirm your attendance and also your name, but we appreciate you putting your names, your CEU in the box. We do use that to verify attendance and just double check the registrations against what people were asking for. Please also bear with us. There are a lot of people on this webinar and a lot of people who are requesting CEUs. It does take time for our team to go through and create those certificates after verifying attendance. I know some of you reached out to me to let me know that you need to have your CEUs before the end of March as part of your licensing. We will have them to you by the end of March, but we've got over 500 people on the webinar today, and it will take us time to get through everyone. So please, if you don't receive them next week, know that they will be in your inbox very, very soon. Let's see. We have enabled closed captioning. Just click the CC button at the bottom of your screen. If you don't see it, hover your cursor near the bottom of the screen and it will appear. Let's see, your audio has been muted for the webinar, but you can chat. I know that Dr. Majid has some questions that she's going to be asking everybody, that you can type your responses into the chat box so that she can respond to the group. That would be really great. But any questions for the speaker, we ask that you please use the Q&A box. That just makes it easier for us to manage the questions that are coming in. So let's begin. It is my pleasure to introduce Dr. Tabassa Majid. She is a program officer in the Healthcare Delivery and Disparities Research Program at the Patient-Centered Research Institute. In this role, she facilitates the oversight of several funded studies and initiatives focused on the aging population, with a special emphasis on those with Alzheimer's and related dementias. Our attention's all yours, Dr. Majid. Thank you. Welcome.
Wonderful. Thank you so much, Diane. And it's such a pleasure to be here. We are really excited to go through a number of aspects of navigating dementia today. I wanted to go through the format of today's webinar for you. So essentially, we are going to be talking through some of the definitions and prevalence that we know are present in different types of dementia. We're going to talk a little bit about changes within the brain and the body. We also will be speaking about risk factors for dementia, promising areas of future research, and then we will take a break, as I heard that a long time without a break is tough on our many participants, to give you a sense to collect your thoughts. And then we'll come back, talk about person-centered care principles, and do a little bit of an interactive activity on personally reflecting on how you might apply these principles in both your practice and connecting individuals that you may interact with resources around you for future webinars here. Again, please use the Q&A box as we're going through the webinar, and I will do my best to answer those questions periodically and at the end as well. Okay, so let's get started with the first portion here, which is really talking about dementia types and definitions. So many of us, when we hear the word dementia, we actually don't know whether or not there are different types or what happens when our loved ones or those who we serve are diagnosed. And so I wanted to start off with a broad clarification in that dementia is a huge umbrella term that can be used to describe a range of neurological disorders. There are many, 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 many different types of dementia. I think the latest number we know about is over 150 different kinds, but that doesn't mean that there aren't groupings that are very helpful for us as professionals and as caregivers to understand. And many of them are subtypes of larger types. So while sometimes it is helpful in the diagnostic process and also in the treatment paradigm to understand exactly what biologically is happening and what symptoms you might see first, second, and third, which we'll talk a little bit about shortly, these are some really common types that I wanted to go through with you today and describe definitions of. And really, the range of percentages that you see here in the graph indicate just how variable some of these diagnoses can be. And some of the names really do change and get combined. You can also have combined types of dementia over the course of the disease. So the most common form of dementia that we know about and we hear a lot about is the Alzheimer's disease form. And this really accounts for about half, if not more, of individuals who have dementia. Sometimes you'll hear the terms probable Alzheimer's dementia. Sometimes you'll hear Alzheimer's related dementia. Sometimes you'll hear Alzheimer's disease. These are all variations of a similar pathology and a similar diagnostic pathway that leads to the most common form here. The next most common is vascular dementia. And this, you can often hear individual providers describing this as, small strokes in the brain that might cause dementia. A lot of that really just means that it is from the vasculature or from the, blood flow system that then eventually goes to your brain that can cause some forms of vascularized dementia. The next most popular, or really the most diagnosed, really is tied with the next two, I would say, Lewy body and frontotemporal dementia. And these are called out as specializations because they are very different in presentation, as well as what a typical individual might look like who has this, than Alzheimer's and vascular dementia. And so Lewy body dementia is a different characterization of small tangles that are within the Tau family, and same with the Lewy body tangles actually, and then frontotemporal are part of Tau as well, which we'll go through in a little bit. But they have different presentations in terms of behavioral, psychological symptoms, others that might be related. When you hear about really, really strong changes in personality and some, what we might call typical extreme behaviors, sometimes that is more related to frontotemporal dementia. And for Lewy body dementia, it's a little bit more related to the Parkinson's type, but in Lewy body dementia, individuals are particularly sensitive to some of the medications that are tried for other forms of dementia, and that can really exacerbate things. So those are two that we like to call out, and there are, of course, many, many more differences with those two that are more well characterized and known, but just wanted to draw your attention to those two names. Young onset dementia is also a really important one to think about. And that can be different than early stage dementia. You can also hear the differences between the genetic risk factors that might come up, as well as what age. So there are different characterizations of that, but generally, young onset is thought about to be with individuals who are not Medicare eligible or younger than 60 or 65. And that can be sometimes more quickly progressing, can sometimes be just a longer pathway, or it can be shorter and more severe. It just depends on the individuals and their families. And then finally, many of us know of Parkinson's, but sometimes Parkinson's disease does have an additional dementia component, and sometimes it doesn't always have that component. Sometimes it just has the physical and motor component. Okay. So if we continue forward here, many of us actually do know that these are common signs and symptoms in general. But as will continue to say throughout the webinar today, and as many of you know from having worked with individuals, or we'll find out in working with more individuals who have dementia or at risk for it, these symptoms are always related to the individual's baseline, right? So, for example, I always like to use this example. If you know someone who doesn't necessarily have a really strong memory, right? If you see a change in that individual, then that is a sign of something that might not be normal. But um, if they always have a strong memory, then changing that is really an important sign that something is going on. So again, someone may have one or more of these signs if they have dementia, and each individual is very different and requires a thorough evaluation to get a diagnosis. So some examples include poor or decreased judgment, problems with abstract thinking, problems with language, difficulty performing familiar tasks, changes in personality, disorientation with time and place, changes in mood or behavior. And again, because we had mentioned that dementia is an umbrella term, we know that some of these happen in some types of dementia and some happen in others. All right. So how prevalent is dementia really? We know that people living with dementia around the world, those numbers have gone up over the past several years. And you can see that by 2050, we have some significant bubbles. Millions and millions of individuals are living with dementia around the world. And actually, when you look at the United States, we have a high proportion of individuals, but it's not, you know, um, that much higher given, our population. And so part of this is because, risk does increase with age. Part of this is also that we're getting better at identifying and diagnosing individuals, but it's a substantive issue. And we wanted to just draw your attention to the fact that there are international, calls for intervention and also understanding of this disease around the world. And I wanted to break this down for you because I think the theme of this webinar today is not only to understand what the different causes and what the different types are, but really to understand what can we do and what can we continue to ask questions about that would be helpful moving forward in the field. So this breaks down the number of individuals with dementia who are projected to really grow over time, between now and 2050 in high income countries versus low and middle income countries. And hopefully, what you can see that's obvious from this graph is that in low and middle income countries, the growth is projected to go up much faster and at greater numbers than in high income countries. And one of the things we need to think about when we see this is that we need to have practical, lifestyle based, risk based, and care based interventions, um, in addition to what we typically think of as drug and pharmacologic based interventions. So, while we have a lot of attention in our society and also in our media about new medications and talking about pharmacology, I want to urge us to think about the combination and also the alternatives to that today as you're thinking about connecting those you serve with resources and also with the practice that you have personally if you are a caregiver or you've experienced this in your family. Okay, so there are several changes within the brain and the body that happen when dementia is diagnosed, and either even prior to that. So we're going to go over a few of those now. Many of you have probably seen a version of all of these different biological indicators of what happens in your brain. So you can see from this particular figure, and I will play a video here in a second. Hopefully, it will work for us. That there are neurons that are connected. Those big round images are neurons that are the cells that are in your brain, and they are single cells, and there are a lot of different molecules and things that are constantly moving forward and backwards and transporting items around the cell. And so the Alzheimer's disease, what we call pathology or indicators, are really that you have plaques there's this big red amyloid plaque that you see here at the bottom of the figure, and tangles, which are these small yellow bunches on the left-hand side in the left neuron. One of them is outside of the neurons, as you can see, and the other one is inside the neurons. In order to be officially diagnosed at the end of, your life, assuredly with Alzheimer's disease, you need both. But throughout the course of your life, you may have indicators that some are building, and that will lead you down, a different pathological path for dementia. But what I want to talk a little bit about is, what does this even mean? Because if this is happening, in your brain and things are changing, what we want to really know is, how does that impact your body and your lifestyle? And so what I'm hoping to do now is share a video from the Alzheimer's Association that some of you may have seen before, that describes how this happens and what the traveling of each of these aspects means for your daily life and what happens. So hopefully you all can
What is
see and hear this.
Dr. Majid, I just want to make sure that you know that we don't see the video or hear it.
Okay, can you still hear me?
We can hear you, yes.
Okay,
The video started and then it stopped and it went back to your slides.
what is
how's that?
Alzheimer's disease?
We can hear it, but we don't see it.
Got it. Okay, let me try that again. Sorry, everyone. Just bear with me here. How about this?
No, we don't hear or see anything.
Mm.
That's okay. Let's continue. And I know we're going to have a 5-minute break or so we can find it and get it ready for after the break.
No problem. Sorry about that. Let me go back to my slides here. Okay, great. So hopefully you can view that on your own time. So let's go ahead and move forward with a little bit of what the video was saying, which is that you can have different elements of these plaques and tangles show up at different points in your life. And what I wanted to demonstrate to you is that we do actually have ways of measuring this external, obviously to looking directly at your brain, but we have some ways of measuring this in looking directly at your brain. So this is just an average. And again, I just want to emphasize the principle that one individual with dementia does not necessarily progress in the same order at the same age with the same aspects as another, but this just gives you an average picture of what we think is going on from the evidence that we have. And so what I can walk you through here is that there's a couple things to point out. One is that when an individual is diagnosed, that's usually somewhere in this early green box here that you see on um, the slide here. And while that may not always correlate with somewhere between the ages of 60 and 70, what we do know is that we can start to see now, even earlier, up to 10, 15, 20 years, that there are indicators of accumulation of some of these amyloid beta aspects of this protein and some of the protein that makes up the tangles early on in what's called your cerebrospinal fluid, which can be taken from your back, which ultimately travels up and down your nervous system throughout your brain as well. That's just an example of something that might indicate that something is happening. But then there's also other indicators, like if you have this gene that is present in a certain variation, that can put you at higher risk earlier on in your life, which is this blue line called the ApoE. But ultimately, what people notice and what drives them to get a diagnosis is usually this change in cognitive abilities, right? So you start noticing those signs and symptoms we talked about early. And sometimes you can get a sense of what's happening in your brain early with imaging. So I wanted to kind of give you a sense of that and just say that you may encounter individuals who are at all stages here, and you may encounter individuals who have moved to several of these, and you don't know, or you just finally find out later on in the process of their disease progression. So, given that, let's talk a little bit about the Alzheimer's disease stages. And I know that there are other aspects of this slide that go through numerical stages. But what I want to do is just speak to you generally about what happens when we have these broader categorizations, because I think it's more helpful to understand what you would see on a broader level than really worrying about what stage someone is in, as we're not going to be diagnosing individuals as part of our jobs after today. So with early on, there is a stage that could progress to Alzheimer's or doesn't have to always, called mild cognitive impairment. So oftentimes you see, let's say, a neurologist or primary care physician, and they might do some tests and say, some things are starting to change a little bit. And so we probably have what's called mild cognitive impairment, or MCI. And this duration, again, is an average. Things are starting to change in your brain. It might be in the medial temporal lobe, kind of right there in the middle. And one of the things that often individuals complain about or note, or the caregiver might notice, is that there's a short-term memory loss that's starting to happen. And so that usually is, go ahead.
I'm
Yes?
sorry. We had a request. If you could move over slightly, you're blocking the slide for the mild cognitive impairment, the other direction. Sorry.
I'm blocking it.
Yeah. Oh, the other way. The other way. There you go.
Okay, no problem. I can also not show the video panel if that works. Is that is that better?
No, no, that just blocked the other side of the slide.
Oh, fun.
Yeah.
Okay, apologies. I'm happy to go off video. It doesn't, but if it helps people see the slide, how's that?
Thank you.
Okay, sure, no problem. All right, thanks, Diane, for letting me know. I can't see what others are seeing. So, all right, great. So the second stage is the 2 year, roughly. Each of these is 2 to 3 years, the mild Alzheimer's, moderate Alzheimer's, and severe Alzheimer's. Now, we've also heard about individuals going through this process for 10, 15, 20 years. So again, it just depends. So the disease basically is spreading during the mild Alzheimer's um, pathway, to the lateral and temporal and parietal lobes. And sometimes you might notice more reading problems, more language related issues, object recognition, poor sense of direction. You can also notice those early. And then in moderate Alzheimer's, you start talking about judgment changes, impulsivity, and short attention. And then with severe, you of course start to have more of those physical symptoms, which include, visual problems, and then you might have some muscle changes, and as well as speech changes that are more severe. Okay, so let's move to the next slide here. So, given that, what increases or decreases an individual's risk for dementia? So this is a little bit older of a slide, but I wanted to talk about it here because this is really a hot topic for us in the research field, and really is something you may really get questions about from individuals in that what they want to know is what can I do about it? So, okay, my family's at risk for Alzheimer's or dementia, and so is there anything that can be done? Can it be reversed? Can I do something to slow it down? And the answer is sometimes, but there's always things that are really good for you, and there's always things that you can do before, during, with the individual, with your family. And so I wanted to take some time to go through this. So the first top half of this figure is really about understanding where the scientific evidence is right now. So what we know is that there are some things you really should avoid, and the blue arrows indicate to you what can exacerbate or increase your risk of having. And then also there's some evidence that's come out that now says that if you have some of these to continue during the disease, then your progression can change as well. Of course, it's not perfect, but if you've had a brain injury, this makes sense, right? We've heard a lot about sports related injuries or other, occupation related injuries that then ultimately lead to some form of dementia. We know that what's good for your heart is also good for your brain. So that's kind of these next three arrows. If you have midlife obesity, hypertension, smoking, or you have diabetes, that is a risk factor for dementia. And then there is some lower evidence, but it is getting more and more robust that if you have a history of some forms of depression or some forms of sleep disturbances, that can also increase your risk. And hyperlipidemia, which is very related to the diabetes, hypertension, cholesterol pathway here, has some evidence as well. It's a little bit less clear that can also increase your risk. So essentially managing what we say for your heart, as I said, your diet, your exercise, your mental health, all of those things are, of course, good for your brain as well. And what can you do to decrease your risk? So, one of the things we really like to talk about, and some of these things, of course, have changed over time, is to really keep yourself engaged in multiple ways. And so I don't want us to get caught up in exactly what these categorizations are, but the principles behind them, because the evidence is kind of shifting a little bit into really trying to figure out exactly what are the perfect components of each of these. And the reality is that we want to talk about this conceptually. So while it says, years of formal education, I don't want anyone to walk away thinking, oh my goodness, if I have a PhD, I won't get dementia. That's not true. You certainly are at different levels of risks depending on what happens, but the idea is that we have seen a correlation, and that there is engagement of your brain through the majority of your life in new educational, physical, dietary training. All of these activities that you are doing keep you active and engaged. And so the more you do that, the less risk you may or may not end up with, holistically, when you take it into account with everything else. Same thing with physical activity. Of course, we know that there is no perfect prescription for how much or how little, you should or shouldn't exercise, but at least moving your body, 3 times a week for a higher heart rate, every day if you can, all that helps what's good for your heart and what's good for your brain. Same with your diet, similar to above. If you have a poorly balanced diet, or if you have um, an extreme variation in your diet, there's some studies that promote the Mediterranean diet for brain health, and there's some things that are, of course, good for your brain, but in general, a balanced, consistent diet. Cognitive training, the idea again that you're engaging in things that are new for you, um, to challenge yourself and to increase the resiliency of your brain. Because what's happening when you have something new challenging your brain is you're making more and more connections and you're strengthening those cells and those connections between those cells in your brain. And then there, of course, is a relationship between um, whether or not you are keeping healthy habits. So some do say, the level of alcohol consumption, of course, in moderation, and some, have some different risks with that. Social engagement has actually increased in evidence where, if you do have individuals that you are engaging with and you are keeping those networks open, that also again helps your emotional and social relationships and keeps your brain healthy and active. All right, I'm going to take a quick pause here and see if there's any questions on that first part of the content. Okay, great. I don't see anything that I need to answer right away, Diane, or do you see anything?
Yeah, I'm not seeing anything. I know there appears to be some kind of a problem with your slide. Some of the informations aren't showing, so I'm not quite sure. It's not you or your name being in the way, but there's something blocking the top of the slides as well as the sides. So I'm not sure what's going on there.
Okay, well let me just pause and try to share again and see if that resolves it. Okay. Let me go through to the next section here.
Are,
And
Dr. Majid, are you, I don't think you're in the presentation mode.
yep, I can do that now.
Okay.
I was just going to here. So
Do you have the, what's that thing called? There's like a bar at the top
I
that
do.
says you're sharing. That may be, if you could move
How's
it
that?
up. Yes, that's it.
Okay, everything open now?
Well, now we have something on the right side, but it's blocking the little symbol. It's a gray vertical rectangle.
And also, since we have a little bit of a break here, someone just asked how they ask questions, and someone does have a question. So we do
Great.
have, if you go to the Q&A box, you can type your question right into that Q&A, and Dr. Majid will be able to read it and respond. I'm sorry, we have so many people, we can't see when people are putting up their hands, so please use the chat box.
Oh, the Q&A
The
box.
Q&A, I'm sorry, the Q&A box.
Q&A
We have questions in the Q&A box. Oh, I think you're resharing. Is that right, Dr. Majid?
Yeah, I'm just trying to figure out if there's a mode I can do a little better here.
I don't know why we have that new block because we know how to.
That's interesting. Maybe we can figure that out together at the break. I apologize for that.
So
Go ahead, Diane.
yeah, so we do have 3 questions, it looks like,
Okay.
in the slides. So we're going to start with Erica. No, Erica's asking about a copy of the slides. We're not sharing slides. We have the program book. And then this is also being recorded and will be part of our on-demand library.
Yeah.
Phyllis would like to know, is there any hereditary component to these dementias?
Yes, that's a great question. So there is a hereditary component to some of the dementias, and some of the young onset pieces that I wasn't able to go into do have a hereditary component. So there's two ways that you can be at increased risk. And a lot of times when you first get a diagnosis, you can do an ApoE test if you want with blood work. But there are at least 2 to 3 other genes that really do have strong hereditary components for Alzheimer's disease that are not the ApoE. So ApoE is very cholesterol and lipid related, and that can be something that increases your risk to a certain point, but there are others that are very strongly hereditary as well. So I'm happy to um, follow up with some of that information. But yes, there can be, although in general it's a relatively small percentage that that is a almost definite with those two genes, and then with ApoE, it's about increasing your risk over time, uh, given other factors, right? It's just another factor that might increase your risk in addition to the others that we went over, and
Right.
that's pretty minimal.
Okay. And then someone is asking if you could explain a little bit if there's a connection with alcohol.
Yeah.
And a follow-up question to that was, obviously there's conflicting research out
Yep.
there in alcohol, whether it's a good thing, it's a bad thing. So if you could
Yes.
explain that a little bit.
Sure, of course. So, as I shared, there is conflicting evidence on some of it, but in general, the consensus is that it is about how extreme or balanced things are in your life, right? So, essentially, with alcohol, it is not something that you should overdo, or and in general, right? It's not advised for you to consume it in excess, much like many of these other things, any, diet or um anything like that. So right now, the evidence is that it needs to be moderate to small amounts if you are partaking, and it should be well controlled over time. There have been many studies that individuals who do consume large amounts of alcohol do have changes that are more aggressive for dementia over time. So that has been shown.
Okay, and I'm going to couple these two
Go ahead.
questions together. First, are individuals that have autoimmune disorders such as multiple sclerosis at
Mhm.
an increased risk for dementia? And then when you answer that, if you could also address the early signs of dementia.
Sure. So, the autoimmune question is a really good one. There are inflammatory components to dementia, of course, but I do not believe there's been a definitive link between individuals who have certain autoimmune diseases and dementia. Of course, there might be changes in your risk over time, but that's not something I've heard has been definitively shown. There is a link between individuals who have Down syndrome and dementia, which is, I know, not necessarily only autoimmune, but is developmental as well. That has been shown where individuals who do reach adulthood with Down syndrome are likely to get some form of dementia. Um, and then Diane, the next one again. Oh,
Early,
early
yeah,
stages
early
of
signs, early
yeah,
signs.
early signs are really in sort of those higher functioning categories, right? So, and we'll go through this a little bit later with some of the case studies too, is that, you start to notice some changes in kind of what we call that higher order functioning. So maybe you start noticing in your loved one, or in yourself or someone you're serving, that maybe they start to have a little bit of trouble processing complex information. There might be something that's going on in career or day-to-day tasks. Some people will notice, like, oh, well, there's a lot more of those reminders or those lists when it comes to complicated tasks. um some will notice changes in driving habits, some will notice changes in financial um arrangements where it's just a little bit harder to do those tasks. um but it really varies from individual to individual as to what you notice early, but usually it's small and it's in more complex tasks. I hope that helps.
Great, thank you. There
Sure.
are a lot of questions that are
Okay, are
coming
they
in.
coming
Are
in?
we good with questions, or did you want to move on and then come back,
We can
please?
we can move, and then maybe around two, when we finish this first part, I'll go through them again.
Okay, sounds great.
Okay,
Thank you.
great. Okay, so
Jade, before you start, at the top, could you do the top block, which was you got rid of the thing that says sharing? We're getting random blocks. I don't know why. There we go. That's beautiful. Let's see how. I'm not sure if the right one's going to block, but we will see. Thank you very much.
okay, no problem. I will keep trying. So the next section is really unpromising areas of future research. And I think what I wanted to highlight here is that there is so much work going on. And what I hope to leave you with today is a message that indicates to you that there is so much hope and so much progress in this area, and it is such a hot topic that there is a lot of money being poured into trying to find better ways not only of treating the disease, but understanding what the underlying mechanisms are and supporting families and individuals and making sure that there can be precise treatments. And so I wanted to share a figure from both the NIH and then some of the areas of focus that we have at Picori, and just say to you that there is a whole host of information out there. And if you're connecting individuals with resources, um, studies are a great way to also find more information. And these are some areas of focus that you might think about when people are asking you questions or you're trying to serve those in your professional network. And this was actually from a recent Lancet publication that talked about what we might need to invest into in the future to really change care and services for individuals. And this was a suggested graph. And I think this is very helpful to understand and goes back to what I was saying at the beginning, in that we hear so much about medication, but look at how much we can do in other areas. We can invest in identifying, reducing, and preventing risk, and that includes genetic, lifestyle, or environmental risk. We can think about how we monitor the disease better over time, or the diseases, I should say. Um, we can think about the translation of research, and the largest pieces, I think, for me, um, are really about the quality of care with individuals with dementia, how that care is delivered, what services are available, which is really where all of you come in such key intersections, as well as understanding what's normal and what isn't, and changing our public awareness and understanding, which is, I would say, one of our weakest aspects in the United States, and we could do a lot better there as well. Okay. The other thing I wanted to do is give you some hope as to what is actually out there. I wanted to give you two examples of what's currently being studied right now. This is just in terms of I work for a funding organization, but I wanted to tell you that there are two projects in dementia that are really focused on care that you might find really interesting. So one of the things that you will likely be helping individuals with are what types of resources they can be connected with and what types of care they might benefit from. And I think knowing the variety that's out there and what may or may not have been found out already is very helpful. This is a study that's ongoing, it's almost done, and it's also laid the basis for the Centers for Medicare Services Guide implementation program, which I know many of you probably already know about and are interested in the future. And this is a direct comparison of 3 ways to address dementia care. And I think many of us, when we think about dementia, we don't even think about the fact that there's 3 different ways to address them, the disease. And it's really about several wraparound services that can be utilized. And there are a number of individuals engaged in the study, and really they're looking at caregiver perceptions, behavioral symptoms, and strain and distress over time. And it's a long study and a trial that's about to finish up. So I think this is very exciting, and we're excited to see, kind of which of these models, if any, prove to be better than the others, or the same, or equally beneficial for different outcomes. And then there's another one that also finished up that really talks about how you might actually manage those early stages and what happens when you have a combination of activities that you can put together to help individuals feel more resilient and manage this mild cognitive impairment stage. And these are just some examples of things that either many of your organizations might offer or you might recommend to individuals to put together. And so they include memory and compensation, cognitive training, physical exercise, support groups, or group classes. And so a lot of times when you get past that pathway to diagnosis, you can think about these concrete things that may or may not help individuals at the stage they're at. So I just wanted to share with you some exciting things that are happening that are on the ground and that we know can work to help prevent or delay dementia at that level. Okay, and then before we take our, I believe, 10-minute break here soon, what I wanted to walk you through is what we know about the process of care management. So this is really from a caregiver perspective, and we know that people can move through these stages emotionally, physically. They can move in and out of these stages or try to manage care differently, but that our job as professionals is to support each stage and understand what you might see. So the first thing that individuals, usually see, which many of you know and are already asking about, I think, are observing changes, right? So those are questions about early changes. You can observe changes in planning, memory, activities of daily living, right? So eating, dressing, bathing, transporting, those types of things. Lack of recognition and understanding, some of the extreme forms of dementia, or as a result of medications, for example, can have delusions or inappropriate behavior with them. There can be, variations on that. And then for the individual who is a family member, a professional, even for the individual themselves, there has to be a time of understanding and processing. And so you could really interact with individuals at any stage of this process, but they're still understanding and processing this over time. And I think sometimes we don't pause to give individuals that grace and time. So the process of getting the diagnosis and being aware of the disease and then looking up information on your own, it's a monumental set of tasks. And so to give individuals time to do that and then to support them during handling a diagnosis emotionally really results in that change between the caregiver and the care recipient. And sometimes it's not right away, sometimes it's over time. And each individual goes through this differently. Each family deals with this differently. I know mine certainly did, both personally and professionally. And we really do want to support the individuals in this process as well, because this will formulate how the approach to the next pieces comes up. And then, depending on when or if or how a diagnosis is shared or given in a group or professional setting to, or even a personal setting to the individual who is living with the disease, they have a reaction too, of course, either awareness, communicating values, communicating changes, and then the idea of formulating a care plan, and I use the word care broadly because care is at home, day to day. It's also in, society and in the workplace and in, occupational or hobby related environments. And then it's also in a professional setting sometimes. There needs to be an understanding of that individual's actions and also their values. So what can we do in order to make sure there's a supportive environment of care, respecting the wishes of that individual, caring for their health and well-being, with them included, understanding safety and understanding how the family fits into this dynamic um, over time. And then, of course, we want to constantly evaluate this as well and make sure that there's good quality, good time commitment, and good coping. So I'd really like you to think about this flow and this framework as you're thinking about the interactive pieces that we will do in the second part of this webinar, because all of these are going to be things that you interact with and understand, and it might be helpful to just know where an individual might be in this process. And it's not as linear or beautiful as it looks on this slide because things take much more time and are much more complex, but this is just a framework that we might find helpful. So I'm going to stop now, and I'm going to stop sharing so that I can actually see the questions and can do a few minutes of questions and then a 10-minute break before we do others. Is that right? Okay, Diane, maybe you can help me figure out where I left off.
Sure, yeah. Let's see.
I got the autoimmune one.
The autoimmune, okay, it starts with a 135. Someone
Okay.
asked about compartmentalizing as a coping mechanism and whether that increases the risk of developing a dementia.
Yeah, no, that's a great question. I mean, certainly making sure that you have good mental health strategies will only strengthen, the resiliency that you may have in your brain. But I don't think I can say, for sure that increases or decreases risk without understanding the whole picture of an individual. But, a healthy way of dealing and processing with emotions or information is always going to help decrease your risk.
And then Belinda, this is a question I get a lot. Belinda
Yes.
Crow asks, what's the value of getting an exact diagnosis if there is no cure?
Yeah, so that's a really, really good question, and I think a lot of people come at this from that lens, which is that, what's the point in naming something if there's nothing you can do about it? And what I hope I've convinced you of so far is that there's a lot you can do about it, right? There's a lot of things that you can actually do that help you to understand how you can have a quality of life that is really important to you, that aligns with who you are, with your actions, with your values. You can also think about the fact that not everyone progresses at the same rate, and there's tons of things you can do to decrease your risk of that progression going at a rate that is different than maybe another person with Alzheimer's disease. And sometimes I do understand this from a pathway of like, you've been to different providers for 5 years, 7 years, and they're still trying to get exact, right? As long as you have a sense of what's going on and you have a plan, I do think at some point there is this provider interaction fatigue, right? Where you don't need to know if you have stage two, aphasia at XYZ, time frame. Sometimes that isn't the most valuable piece of information if you'd have a label. But in general, it's really helpful to know. For example, at the beginning, we talked about the different types of dementia that are not Alzheimer's, that are very sensitive to certain things, right? So you need to know if you're going to go ahead and get any other type of, let's say, surgery or intervention for any other health conditions you have, there may be medications you really shouldn't have because that's really not good for you for a certain type of dementia or something that's not specific to Alzheimer's disease. So there's a lot of value, and I would say that it also helps the individuals around you help support you, to the best of their ability. I don't know if you have more to add to that one, Diane, but that's a
No,
common.
no, and one of the problems that we see is so many people are go to their primary care physician, they get a diagnosis of dementia, they walk out with a prescription, and they never have follow-up. So, do you have advice for those types of transactions with their physicians?
Yeah, I mean, I think the follow-up is hard. We certainly do have a different um aspect of having individual specialists versus how quickly they're available, and so I do think that is a general problem. Um, but in general, the earlier I would say that you can really have a sense of what is or isn't going on. Sometimes it's not always bad news when you have the follow-up because primary care physicians and others who are doing screenings, a screening and a diagnosis is not the same thing. So when you have that comprehensive understanding or that evaluation, you may very well I've seen individuals who have a reversible kind of dementia at that point, right? I've also seen individuals who never progress past a certain point. Um, so there could be a number of pathways that you find out when you do have that follow-up. So we would encourage you to do that. We know it's hard. We know it takes forever. But we would encourage you to do
Great,
that. Okay,
thank you.
sure. I think I'm on the benzo
Did you find
question.
perfect. Yep. So
Okay,
yeah, so you can just scroll through and
sure.
answer them. So thank you.
Great. Do benzodiazepines have the same neurotoxic effect as alcohol? It depends. It depends. It's the best answer I can give you. It depends on the person and what kind of benzos and how long over time. But that's a really good pharmacology question that I don't have exact answers to, but I believe it depends. What about cognitive decline from COVID exposure? Yeah, great question, Janice. So yeah, so long COVID is something we really and even just general cognitive decline from COVID. There are studies that are being conducted on, I believe, both the NIA and PCORI had huge supplements on whether supplemental funding, I should say specifically, on whether or not COVID and dementia could be related, over time. I don't think we know the answer to this yet. The immediate cognitive change from COVID versus the longer term effects, I think are two different questions. And we know the immediate mostly resolves, but the longer term, we have yet to find out. There are studies though being conducted on it. Great question. Are the genetic markers worth testing for and at what age brackets? Yeah, it's a great question. If you know that you have a family history and someone in your family has been tested for some of the young manifestations and young onset, some families do make the decision to have their loved ones tested, or at least communicate with their children there's a risk. Some of these 23andMe and related genetic um, kits will test automatically for ApoE, which is the one I told you that has some amount of risk, but really is combined with other risk factors. And the age bracket, most people will get tested around their 50s and 60s, but it doesn't mean you can't get tested later. Either you have the gene or you don't. That's kind of nice about the genetic testing. Okay, I think I answered the benzo question. What is moderate drinking? Yeah, no, I know there's been conflicting evidence, on that. And I think the definition of that is still being defined. I mean, I think from my perspective there, I knew that there was that controversy about red wine and then some others. Again, it goes back to kind of how balanced and controlled you are over time in your life for alcohol consumption. The slide with the common forms of dementia again. Yes, of course, that one is, I can put that up at the break. But that one is essentially the from the Alzheimer's Association or Alzheimer's Society as well. We can also link that, I think, Laura, after this. Okay, is there a significant correlation between severe mental illnesses and dementia? Yeah, so that slide that I showed about increasing risk, there was some evidence that was specific to the history of having depression and related disorders between that and dementia. Again, we don't know exactly, you kind of have to test each one or look at individuals over time. And so we do know that there are some related mental and behavioral health conditions that do put you at some greater risk. But again, it's about how well they're managed and how well that correlates with other risk factors over time. So in some aspects, yes, but not every single one. The signs and symptoms, happy to also share that one. I'm happy to just make sure there's links to certain figures that I've been using. Are hearing issues and tinnitus a risk factor? Great question. We have seen increased evidence of unmanaged hearing loss as a risk factor for dementia. That is a pretty hot topic as well recently. So if you do start to have some hearing changes with age, you always want to manage them in a way that helps you to process and function to the highest level that you can. It's all related, right? So if you're having trouble within, your sensory environments, that's going to impact how your brain is processing things over time. And so we see for a lot of older adults that you're kind of putting off that hearing test or not, really going to see if you need a hearing aid. We would just say that, the better that you can understand that, the better that you're interacting well with your environment, the better it'll be for your brain health. Okay. Boy, there's a lot of questions we're still going through, but please feel free to take a break if you need. We will start up again at around 2:10 with the main content. All right, when you notice these things, is it encouraged to stop them from doing day-to-day things, or do you encourage them to do as much as they can handle? That's a great question. So your brain is kind of like your muscles, right? You should use it as best you can, or you start to lose it, right? And you should challenge it with new things. So I actually think that we have this aversion to when individuals can't do something that we just say, oh, well, you can't do it, that's it. But within moderation, you can take appropriate risk and make sure that the individuals are having as higher level of functioning as that they can. All right. Most dementias are progressive, but what about vascular dementia? Yes, so there has been specific work done on vascular dementia as well. Um, there have been instances of vascular dementia that are more progressive than others, and there are subtypes there too. So I think the answer to your question is if we treat, or you also have a question on modifying the risk factors for future strokes. Are you halting the progression of vascular dementia as well? Yes, some types of them. Some types of them. So treatment for stroke is related. Can we hear about which medications adversely affect dementia conditions? Yeah, so with Lewy body dementia, we know that there are actually antipsychotics and other psychotropic medications that will adversely affect those individuals. So sometimes when you see behavioral changes, one of the things that's prescribed is in that category, and that can really exacerbate the overall dementia progression in that particular case. That's what I was referring to. There are others that impact other types, but that's just one example. A lot of caregivers are not aware of the available resources, especially caregivers from other cultures. Yeah, and what are some sensitization strategies used to reach such ones? It's a great question. So there are a lot of community-based organizations that are now starting to have um, resources and advocacy, um, you know, either material or individuals who can, at the very least, have cultural sensitivity training, but also understand how to promote these resources from in other languages with other cultures, have different groups that are tailored towards that. And some of them, stem from the Alzheimer's Association. Some of them stem from other community-based organizations. I would highly encourage you to keep open as best you can. Sometimes you have to find literature yourself. Sometimes you have to know someone who is also from that culture who might be connected. I know this is really, really hard, and this is something that all organizations really need to do a better job at. But there are some efforts being made. There is also research in this area on health disparities in underserved populations. If you have a loved one who had dementia from strokes and you're seeing signs, how should you say, "Hey, mom, I think you should get checked"? Yeah, this is really hard, and it's a tough conversation to have with a family member. Sometimes you can use sort of a normal checkup with a trusted provider to get that first step for screening encouraged and done. That would be a first pathway to recommend. And or you could have, a trusted individual who has a good relationship for this individual who might express concern and have an encouragement there. But it's a really hard conversation. There's no perfect answer. All right, I'm going to go through a couple more of these. Can statins lead to dementia? No, not necessarily, but there have been links between, of course, the vascularized forms of dementia and the abuse of high cholesterol or statin specific medications, but they don't it's not a one-to-one correlation like that. I mean, treatment with statins is good for your heart most of the time, if it's done appropriately. Okay. I said it depends to a question on whether one can discourage a patient. Yeah, I mean, I think it depends on how an individual reacts to medication and also what their other presentation is. Certainly I'm not here to give individual clinical advice. So I would say that is a holistic answer to discuss with a provider there. In the last session, it was mentioned that sleep aids can have negative impacts on the brain. Are there safer options that won't negatively impact the brain or contribute to dementia risks? Yeah, I think I'm not sure. Maybe Diane, we can refer back to that particular reference to sleep aids and what that definition was. I'm gonna probably skip this one because I'm not really sure what was shared last time. Okay. Please discuss options for moderate to severe dementia patients who don't have family resources for their care. Yeah, I mean, this is also really challenging. A number of individuals are cared for by well-meaning, either neighborhood resources, local community organizations, family members who are able to care for them. It doesn't mean that just because your individual has dementia, they absolutely are going to go to a community that specializes in that. That's not financially or desired for a lot of families necessarily. And so I would just say, kind of a comprehensive set of community-based services is also an option. There's also modifications you can make to a home that the person is in to help with some of that more severe function change, as well as bringing providers into the house to help. Home care is also an option that many families use. Yes, I did say that there are blood tests available that do not necessarily identify some types of dementia. So remember that the diagnostic process has multiple parts, but there are blood tests that can test for um, genes that could increase or decrease risks depending on how much and in combination with other diagnostic measures. There are new blood tests that are coming out that have some profiles in them. They are not widely available outside of research yet, but they are in progress. So that is very exciting. Yes, the distinction between young onset versus early onset. Yes, so young onset, I believe, has an age, has a very age specific and genetic specific component versus early is just a broad term. So I believe to officially have young onset, you have to have both the genetic and the age risk factor. All right. Can I address the association between chronic inflammation and Alzheimer's and related dementias? Yes, and you're interested in dental health. Yeah, so there actually is some new research out on periodontal disease and other events that happen later in life in older individuals and chronic inflammation. There are inflammatory markers that have been shown to have some link to Alzheimer's and related dementias. But again, I think it's all about keeping that system active, your inflammatory system active, but not under too much stress, right? So chronic inflammation would be like it's constantly under stress if you think about it in lay terms, and that's also, of course, going to activate things more. So I can certainly it's maybe a little more scientific than we have for time for today, but there's some very interesting work on dental disease, yeah, and inflammatory pathways and dementia. Yeah, absolutely. That's a good area to be looking at for new stuff coming. All right. Is there any data showing correlation between Alzheimer's and environmental and food toxicity? There may very well be. This is not necessarily my area, but there is some research on what the environment has in terms of what's in the air and how individuals are processing that into their bodies in general, right, with chronic diseases and longer term Alzheimer's and dementia. But I believe it's still very correlative. I'm not sure that we've had definitive answers on that one. What factors have been shown to increase the chances of progression to more severe degrees of Alzheimer's? So I would refer back to the risk factor slide. Again, what's generally good for your heart is good for your brain. So what's bad for your heart would be bad for your brain, even the progression piece. Generally less of everything we talked about, right? Less physical exercise, less control of your diet, less social engagement. All of those would have impacts potentially on your progression. Is vascular dementia hereditary dementia? No, not necessarily. What do you think of the non-pharmacal research on ultrasound to treat dementia? Fascinating. I haven't heard of exactly maybe what you're talking about, Emily. I would be curious to know what in ultrasound is being used to treat dementia specifically there. Okay, and I think this is a personal question on whether or not her symptoms for this individual's mother has been diagnosed. Well, in some situations, individuals A do get misdiagnosed, but B that she could still have dementia that hasn't progressed, and that's a good thing in a lot of ways. And are there specific tests that can be taken? So essentially, if you were to go for a second opinion to get her re-diagnosed, they would do the whole evaluation again, just to see where she's at now. So it would be, neuropsych testing, probably some of the reversible forms tested for, some of the more biologic pieces, and then also an evaluation of what's going on with her physically, maybe some imaging too. So they would do the whole thing again. Do I recommend finding a board certified geriatrician for dementia patients? I mean, in general, you want to find someone who does have some specialization in this area when you get someone evaluated or diagnosed, but starting somewhere is always better as well, even if they're not per se geriatrician at first. Okay, that it, Diana? I think it reached the last one. So I think it is now 2:10. We'll go back, stop my video.
Yeah, I'm sorry I couldn't get to my screen real quick. Yeah, why don't we go ahead and take a quick 5-minute break? I know you probably need to get a drink of water and catch your breath. So why don't we come back at about 2:15 or so? Would that be okay?
That sounds great, and I'll try to reshare at that point.
Okay, great. Thank you. Okay, we're going to get started in just another minute. I do want to address a couple of questions or comments that I just saw in the chat box. Number one, someone asked what time the webinar will end. We will be finishing up by 2:45. If Dr. Majid is able to stay on and take additional questions, we can certainly ask her to do that, but we are scheduled to end at 2:45 and then provide time at the end to complete the post survey. A couple of people have asked about 2 surveys and repeat surveys. We are tracking change from webinar 1 through webinar 7. So if you're attending, each time you participate in a webinar, we are asking that you participate both the pre-survey and the post-survey for that individual webinar. You'll see questions that you may have seen on the previous webinar if you attended, as well as very specific questions to this webinar. So we do ask that each time you use the same ID number and that you do complete both the pre-survey and the post-survey. That will just help us with our reporting back to our funders. Thank you.
All right, we're ready to get started again. Okay. So we've gone through a couple of areas of promising research and a couple of studies, as well as the process of care management. So what I want to spend some time on today is really thinking about person-centered care principles. And I would ask that this be a little bit interactive, so I will probably put the chat box up to see your reactions. But let's go through what we mean when we say person-centered care. And I know many of us are not necessarily in direct care settings, but many of us are going to serve individuals who are coming to us at some point in time. So I'm going to use the word care broadly. And the graphic on the left here is really thinking about how you can put the individual who's living with this process at the center of everything you do throughout the process. And we kind of went through this already, but I wanted to just leave it for your thoughts here, because there are times when in our medical system and in also our community-based system, we don't always keep this center. And so I would encourage you in your personal practice to do that. And that's really about that relationship between you and the individual and their family who's going through this together. And oftentimes you are the one as the professional who's gathering information, identifying their goals, exploring the options, helping the individuals and families assess risk and benefits, agreeing to what the plan is, and then delivering either resources or support that really should be in line with the individual's wishes. And so sometimes we spend a lot of time talking to the family member about what they want and not thinking about it from the perspective of what the individual wants. And it's always a balancing act, but really remember who is at the center of all of this. And listening to feedback is also really important in this process. So I would want to, think about this, and I know we don't have time for each and everything to be in the chat, but when you think about words that come to mind when we say person-centered care, what I want to ask you to do is, aside from the ones that you see on this slide, I want you to think about things that we use in our current system that don't encourage person-centered care, but that aren't, positive terms of choice. And I think that really raises our awareness when we're thinking about this process as well. So can individuals just type in the chat? Let me see if I can just do this real quick. Okay, to take a look at my chat here. And I know it might cover something. Time limited appointments. Yeah, these are great ones already. Thank you. Making decisions without including them, set times for meals. Absolutely. Insurance companies not listening actively, checking your boxes, some challenges with language, set times, right? Set schedules. We love schedules for individuals that we make up, not what they want, right? So caregiver thinking of themselves, this is great. So all of these things, no fluidity, all of these things contribute to how we might have individuals who are struggling with care in a way that we have to then shift that mindset to serve them in a more person-centered manner. So this is great. Thank you for some of those. I know there's more coming. Keep going. So what I want to do also is share with you this basic model for care, and this is something that if you're looking for more information on it, it would be really great to go to the New York Department of Health's website. This has actually been published, tested. There's actually case studies there, and we don't have time to get into all of it today, but I just wanted to leave it with you. This is very similar to those of you who are familiar with Maslow's hierarchy of needs, and it's a way to really walk yourself through each decision point in thinking about the individual. And so we're going to go through a little bit of an exercise here today, and I'll walk you through my basics, for example. But really, it stands for all of these different aspects of how you might tailor something for an individual. So, as human beings, the very basic need is, we all need food, water, oxygen, safety, rest, human stimulation to live, right? And sometimes what happens is when individuals don't respond in the way that we think they should, especially with dementia, we think that they don't need any more stimulation. And we do, we do things in our care environments that remove that stimulation. But actually, if you don't have human stimulation, eventually you die, right? I mean, we know that from having, kind of a fictionalized version of it when we're talking about the Tom Hanks Castaway, right? He even made himself a little volleyball that he could talk to. Because when you don't have that stimulation or that interaction, you're alone and you don't actually have that reciprocation. You really don't thrive as a human being. That's one of our characteristics. So that is actually a biological need. I know a lot of times we think it's like optional to socialize with other individuals, but it's actually something that we need as human beings. Then there's activities of daily living, which we all know. We focus on that a lot during our care. There's also the societal needs that we each have. We each want to have a personal identity. We each want privacy. We each want to understand how we match in society. We also need to connect with others. We need love and belonging and social role expression and confidence. And we need to either care for someone or be cared about, or both. We also want to really find that creative spark. And I think this is what a lot of us who are really passionate about this work love, is that when you find what happens to an individual when you get it right and their face lights up, right? That is the spark of joy, right? That's something that we really strive for, and that's creative. And then of course, highest is, symbolic expression of how you can just be all that you can be, where everything kind of comes together. So these are just ways that you can think through how you might serve individuals as you're interacting with them. Okay. So when we go through our personal practice and reflections, what I want you to really think about is how you might be able to pull some of the principles that we're talking about into your personal practice. So I would like you to take a moment, please, and imagine your perfect warm drink. And see if, now that I've put this slide up, I'm going to go back to the other one. See if you can sort of do a little bit of a descriptor using maybe some of the terms here in this basics model that would help either craft a perfect warm drink for you or for individuals that you're serving. And I'm going to give you actually some time to do this, maybe about 4 or 5 minutes, and think about that. We'll just pause for a minute while folks can do this. Oops. Apologies. I'll go back to that. There we go. Are we talking about what makes up the perfect warm drink? Let me clarify what we're talking about. If you were to craft a perfect experience of having a warm drink, it's not so much what the drink is, but how can you make food and drink an enjoyable experience? And if you hate warm drinks, then say that, maybe it's a cold drink, maybe it's something else. But we're just trying to pick an example that makes you think about everything that goes into a perfect moment. Because when we're having moments with individuals that we serve, we have to link moments that are really good together to make really meaningful minutes, and then minutes linked together to make really meaningful time periods and experiences. And then slowly those experiences get better and better to make a meaningful day for that individual. So what I want to do is try to shift us from the perspective of this is the schedule, these are the tasks, these are what needs to happen, these are the services that they need, to let's talk about a small moment that could be really, really meeting all of their hierarchy of needs and then build out that way. So if it is a beautiful raspberry leaf tea or whatever else, that's fine. Okay, wonderful. We're getting some really good answers. So I apologize if I'm blocking people to look at the chat. I will move it in just a moment. So we've got one that says warm, creamy, calming tea in a fancy teacup while wrapped in a blanket. Oh, so wonderful. Yeah, that sounds great. And what you've done is you've created an environment and a picture and an image in all of our minds of how that feels, right? So I think that's the main piece here. If we're really thinking about these needs, how does it ultimately feel? And maybe and see how different that looks for each of us. That's the other thing, right? We're all unique and we all have these different needs. Hot tea in a large mug. We've added cookies and a couch. Awesome. Drinking tea that I've harvested from my own garden. So awesome. So that is you're hitting on a bunch of these in the basics model, right? You connected with a hobby, so there's something that you're contributing to society by producing your own tea. You also are connecting with yourself, the environment around you outside, while meeting a basic need. Right. And the idea that you're also interacting with a natural environment. That's great. Sitting outside. So where you're sitting, what that physical location is while you're drinking that cappuccino. Awesome. That's important as well. The way it smells. I'm just picking out some things from multiple people's now. A comfortable position, something with good connections for this person. Okay, so maybe who's around you, where you're sitting or where that individual is sitting, a moment to talk or pause and engage, smelling the drink. This is great. So you all are getting it. I think in terms of really understanding what would make something really meaningful. So I would like us to hold on to this while we have recommendations for individuals around care. And there's a lot more, as I said, for the basics model that you are welcome to peruse on your own, but just wanted to share that as a helpful way to think through what you might bring into your personal practice. Okay. Thank you so much for participating in that. We have crafted several experiences of a warm drink. And then I want to talk through a number of hierarchical things that you can do to bring into your personal practice as well at every interaction. So you have a choice, right? When you're interacting with someone, you can slow down and empower the person and the caregiver. You can provide evidence-based information and you can build trust. But one way that you can also provide information is just by providing it, and also have sometimes a rushed interaction with that individual. And so I think in this work, it's really important for us to establish that relationship and give that gift of as best you can, the empowerment and the trust that you can provide. And these are really principles that govern how you can then get to really good decision making. So this isn't stuff that's just really nice to do. It's just evidence that we know works to build a comprehensive plan, an effective way to serve the individual and the family, and then to share decisions over time. So empowering the individual, how can you empower a person in your care, or within your resources? So one set of suggestions is here. Um, I love that someone added music to their pecan latte experience. That's also wonderful. Another sensory input that's really important. Um, Thank you for keeping those coming. So when you think about empowering those in your care, these are some things that we know that you can do. And if you have any others, feel free to drop them in the chat. Um, think about the language that you're using, right? When we think about that diagnosis or those labels, I mean, it's still a person living with dementia, right? It's not necessarily your patient. Even client sometimes can be a little off-putting. That's their family member, you know. So these are some examples of language that we might not think about as much, or even saying something very clinical, like activities of daily living. Like, most of us don't think about the fact that we took a bath as an activity we did to live daily in our speech, right? We say we took a bath. Um, so, and then, think about that care management flow chart where there's emotions and there's vulnerability over time. When you have a good relationship with someone, you most likely can get them to work with you better. That's true at work. That's true, in your relationships with those you serve as well. Um, and this is hard, and I think many of us who are passionate in this work do this a lot naturally, but your own personal experiences can really help build that relationship. Um, and acknowledging that the person who's reaching out to you actually is reaching out of an act of bravery that it takes to reach out and ask for help. And a lot of times, and this is particular for our caregivers and even for individuals, it can be both lonely and rewarding, right? Because serving someone, and for us too as professionals, serving someone is oftentimes why we're in this work, but caring for someone is really hard. So I have some really good ones that are also coming up in the chat, and I'm glad this is producing some really nice brainstorming, giving options, providing choices, allowing the client to guide the day. Absolutely. Yes, music can have a huge impact. There's tons of research up and coming and already done on some of that. Grounding things in nature, sure. So I hope that most people do get that benefit, but oftentimes we see that they don't. Great. So empowering those individuals, and even just your tone, paying attention to all five senses. Wonderful. So that's kind of the first step in that practice. Providing good evidence-based information, and I will move the chat down again. These are just some resources, and a lot of them are actually focused on Alzheimer's, but there are tons for other forms of dementia as well. But just making sure that you actually do have resources that are helpful and evidence-based, and they're not random, and they are also not, um, you know, mass consumed non-evidence-based information. And so this is hard to come by. There's a lot of misinformation out there, but we encourage you to provide evidence-based information. And I'm happy to also take other suggestions or ways that you can also do this. But that is an obvious one, and it doesn't have to be, organizations or resources at these levels. We also have just guidelines and things that are evidence-based versus things that you just heard about. Okay. And then how can you build that trust? So when you think about concepts from shared decision making and how that is the result of strong collaboration and trust, these are some things we think about. We think about the fact that you need to ask good questions. There needs to be an expression of goals and values from all parties. There needs to be a safe place to raise concerns, and you need to be able to bring in multiple viewpoints. Are there other ways that you all have found that build really good trust with individuals in your daily life? move slowly, explain everything before doing it, friendly demeanor. Sure. So I think making sure that you do not come in as a disruptor in that environment is a really good first step. Removing yourself from the center and keeping the client there. Take your time. Eye contact, those are great. Ask questions, be consistent. Yep. Being patient. Yeah, and I think one thing that really sticks out for individuals who have dementia, especially as they progress, is that the individual inputs around them, whether it be people or their environment, are their new sources of information, right? Because they're over time they are not their own reliable sources of information, and so you have to trust the information you're getting and the person and the environment that you're getting it from. And so yeah, this is great, Amanda. Be a non-anxious presence, honesty, repeat the goal so you know you really heard them and you care. Yeah, these are fantastic. Building trust. And it takes time and effort. Remembering that they have a life legacy beyond where they are now, that's fantastic. Yep. I tend to really you tend to change your approach in how you relate to people in different types of environments and households. That's very savvy, Ruth. Yeah. That is something that we think about, right? It's personalized. It's all personalized in the approach. Having empathy, also a great one. Wonderful. Thank you for these. These are great. Non-judgmental. Okay. So I just wanted to leave you at, at the very end here, and we'll wrap up a few minutes early or than 2:45. But putting it all together, there's several scenarios in which you may think about the basics model, you may think about your own approach to building trust, and you may or may not be helping directly with this, but these are some things that you may hear about, or they may trigger some of these conversations. And I would just encourage you to go back to these. So these are some that we've heard in our professional setting where, someone's very concerned about someone driving dangerously. There's some short-term memory challenges at work. There might be some concerns around appliance management or cooking. All of these have elements of safety that can often override a person-centered approach. And that's why we put them here, because oftentimes we want to either recommend, or the family member or the individual wants to emphasize that what's happening is not safe. But there is a level of risk that humans beings take every day, and we don't want to remove that to the point where that's also dangerous for us in a different way. Walking alone outside, dressing and eating, financial management, managing medical appointments, all of these things have complexity to them. So we just wanted to leave you with some food for thought. Perhaps you can take some of these and build out, kind of your basics model, or think about someone that you work with as how you might approach this over time. So just wanted to leave you with that food for thought. I've had a wonderful time. Thank you so much for interacting in the chat so well. And I will keep reading these over time, but I'm going to stop at 2:40. And if there's any questions, I'll happily look at the Q&A. But I'm going to stop sharing my screen and turn it back over to, I think, Diane.
Thank you so much, Dr. Majid. This was wonderful. And you can see just from the number of questions in the Q&A, I'm looking and I see 50 new questions since the last time we logged in. So just in the last 40 minutes or so. So I don't want to take up time, but why don't you go ahead and let me find where we left off. Research on non-pharmaceutical research on ultrasound to treat dementia. Have you heard of that?
I have not heard of that one. I think did we go
Did you do
past
that?
that? We did that one, yeah, and we
Colitis.
did.
Oh, I'm sorry. Yep.
That's okay. No. I think 210s when I stopped. So let me see if I can find that. Okay. A board certified geriatrician. Okay, great. Let me see. Please address the studies that lately seem to implicate every medication on the market. Yes. Anticholinergics especially makes one apprehensive to even take a Benadryl. I know there's so much stuff coming out about different medications and what happens. I would just say a lot of times we have to wait and see when the studies are more definitive. And unfortunately, What happens is when something small comes out or something is shown, it's very it's made to sound as though it is actually evidence, but when it might just be one or two or three or small sample. And so I would just say wait and see until your reputable sources tell you that is actually what's happening. Um, it seems that the future estimated increase in numbers of individuals is going to increase significantly. Yeah. What do you believe the main factors in reducing this trend would be? Yeah, that's a really good question. I think first of all, our population is aging globally. So you sort of have this risk um, that comes with aging that is just naturally who the population is in the world. So I think in some cases, we're not going to, stop people from living longer. That's a really good thing in a lot of ways around the world. But I think the more we can do to keep everyone healthy for longer, the better, that trend will be over time. And I think I answered a tinnitus one already. Um, how can a family be helped if the client is unsafe? Yeah, and completely resistant to any help and says they need no assistance. And, we all have had that example that really escalates over time. And unfortunately, um, sometimes it takes a bigger incident to really have a family member or a client seek those services, and sometimes you've done what you can and you've done your due diligence, but a family can definitely be helped by continuing the conversation, being that open resource, making sure that you are the one they call when something does truly happen. um it's really hard to find out what the right entry for that person might be unless you really build that relationship and get to know them. It's a really hard one. Will you please put up the slide on common behavioral indicators across dementia? Oh, the signs and symptoms. Yes, I can certainly make sure we link that. How do you handle a dementia patient with aggression? Yes, so that there are a whole host of evidence-based ways to do that. There's also guidelines from the association that help with that, but the biggest factors are making sure to predict, prevent, and de-escalate, right? So before someone becomes aggressive, there might be some things that trigger that, predicting what happens and why, and preventing that, and then de-escalating if it does escalate, are really the three um, principles behind that. What diagnoses are reversible dementias? Yeah, so there are some things that are biologically, um, that can happen to reverse. So there's some vitamin deficiencies that can result in reversible, I should say, dementia. There's also certain things that happen, when you're under anesthesia post-surgery that has like a mild form and then it goes back. And that's really not usually, those are not usually classified as like full-blown dementia. Those are usually if you have sort of the right, that's why one of the first steps is doing a significant amount of blood work, because you want to sort of eliminate those underlying causes that could just be causing something temporary. But there are a number of other individuals, some are reversible. Okay, I think we reached that end there.
Yeah, this was wonderful. Thank you so much. Someone did ask if we could get the slides. Yeah, we're not sharing the slides right now because um, we're putting together the program book, which corresponds with the slides. We are making an on-demand library. All of our events are being recorded, and so you'll have the opportunity later this summer. I will send a link when that becomes available. We'll put a link out to our new on-demand library, which will also be linked on the Department of Aging's website. And so you'll be able to go back through and listen to the webinars and see the slide decks. But the slides are proprietary for the most part. And so there are some people who may be willing to share their slides, other people who won't. So we just decided we're not going to take anybody's slides for sharing at this time. So we thank you. A lot of questions about the surveys. Remember, we do have over 500 people who are registered, who are needing to be verified, who we need to send certificates to. I'm a small team. I just have, a few, I've got a great team. We're very productive, but we're also a small team. And so it does take us time to get through the CEUs to make sure that everybody's verified. We have to cross-check against our webinar recording because we do get the timed information to make sure that people who are here for CEUs did attend for the entire period. So please bear with us. You will have your certificates for last week and this week by the end of this month. A reminder that we do have an in-person event coming up on March 22nd. We have reached capacity. That is an in-person venue, so we did have a limited number of seats available. We have reached capacity. We'll be reaching out this week to verify your participation. It is a full day, so we will have a continental breakfast served as well as lunch and an afternoon snack. So we'll be sending some information to that. If you registered for the in-person session and you can no longer participate, we would appreciate if you could just email us back once we send you the information that just verifying that you will be in attendance or that you can't. And if someone drops out, then I can contact the people that are on our wait list to attend that March 22nd in-person event. And we'll send you the full information about that this coming week.